Okay, good morning, everybody. I'm Professor Shukla from New York. It's 8 a.m. here. Can you please confirm that you can hear me?
So,
Okay, great. Thank you. Welcome to the webinar for Surgeons for Surgeons, the Global Surgical Network. If you haven't downloaded the app and become a member, please do so, both on the App Store and on the Google Play Store. Also follow us on social media, on X, LinkedIn, on Instagram and Facebook. The handles are shown on the screen. So today I'm going to be speaking on early onset colorectal cancer. As you are all aware, March is Colorectal Cancer Awareness Month. And this is a very important month for us to refocus our efforts on preventing colorectal cancer. And that can be done by screening. So if any of the audience is 45 or older, I'm hoping that you have had your colonoscopic screening. I can confirm that I have had mine at the right age. So the recommendation is 45 and over, and I'm sure we'll discuss that. As most of you know, I'm a professor of surgery in New York, and more recently, I've also been privileged to be appointed as a professor of public health, and that's in recognition of the work I've been doing with screening and preventing colorectal cancer. So with that, I'll start my talk. For this topic, I have no conflicts to disclose. And today, in the next 30 minutes, I'll be introducing the topic of early onset colorectal cancer, which really is cancer affecting persons below the age of 50, defining the problem both in the US and globally, and what initiatives are ongoing to fight this increase, and also then ending with the early onset cancer program, which I co-direct for my health system. So there's no doubt that colorectal cancer is a leading health challenge, both in America and globally. Worldwide 2020, third most common, second most deadly. So this is the reason why we really need to focus. The incidence is higher in highly developed nations, but unfortunately, it's also increasing in middle and low income countries and is likely a lifestyle disease. This is the projected increase in colorectal cancer, which we are seeing, as you can see in the next 15 years or 14 years, there's going to be an increase in the incidence of rectal and colon cancers, and we all need to be prepared to deal with it. When we look at the incidence from male and female perspective, and the top part of the slide shows the estimated new cases, and the lower part is the estimated deaths, very consistently colorectal cancer is here in the top three. And that's an important statistic for us to acknowledge. Also, when we look at the patterns of incidence, unfortunately, GI cancers are increasing. The highest numbers are colorectal, stomach, and pancreas. And when we look at the smaller subgroup, the fastest growing incidence within the GI group is appendiceal cancers, pancreatic cancers, and intrahepatic bile duct cancers. As you can see here on this graph, the GI system is clearly to the right of the median, which shows that there's a statistically significant increase in the number of these incidents and deaths. Also, what we can see here is that the median age of patients being diagnosed with colorectal cancer has reduced from 72 to 66. But what is more worrying is this left side of the slide, where almost a quarter are under the age of 54. So there's something going on where this cancer is becoming a cancer of the young. So how do we define and identify the problem? As you can see here, that early onset cancer, which is under the age of 49, in males is the leading cause, and in females, it's second only to breast cancer. This is an example of one of our real patients diagnosed at 36, and her only symptom was what she thought was a stomach bug, and it turned out to be a cancer. The left-sided graph is an important one because what it shows is that females under the age of 50 are more likely to get colorectal cancer as compared to males. That is not only worrying, but it also opens certain opportunities, which I shall discuss in my next few slides. When we look at the annual percentage change, this is for colorectal cancer. The blue line is 20 to 34-year-olds, and you can see there's a 90% increase by in the next 5 years. And when we look at rectosigmoid and rectal cancer, 124%. So these are important figures as we speak to our patients and the community at large. Also, when we look at what is projected by 2040, the early onset cancer, colorectal cancer, is actually going to overtake a lymphoma, non-Hodgkin's lymphoma, and become only second to breast cancer. But unfortunately, it's going to be the number one cause of cancer deaths, even more than the breast cancer, despite breast cancer having a higher incidence. When patients who are younger than 50 get diagnosed with colorectal cancer, because that diagnosis happens late, you can see here that the regional disease is more commonly found, and that clearly impacts on outcomes. We want to find cancer in a localized stage, not a regional or distant stage. But because younger patients with cancer are not suspected to have cancer when they meet their doctors, that diagnosis happens later. And that's why they have a stage 2 or stage 3 or stage 4 disease. When we look at the colorectal cancer incidence within the US, the highest incidence is here towards the southern states. But when we look at it in percentage increase, it's happening in the western states here. So there's a problem which is happening. We have to identify why in the west of the US this incidence is much higher. And is it going to reach the level of incidence which is happening in the southern states? And is this linked to medical problems like obesity, etc.? So when we look at the cancer continuum, there are important areas where we can all focus on, and that is really etiology, prevention, and screening. So this is where we really want to focus. Can we screen and find these cancers early? Of course, once a patient is found to have a cancer, to stage that cancer appropriately, treat, and then hand them over to survivorship is the cancer continuum. So what is driving this early onset cancer? If someone was born in the 1950s, their risk was less than someone born in 1960. Someone born in 1990 has double the risk of colon cancer as compared to someone in the 1950s, and 4 times the risk of rectal cancer. So this is called the birth cohort effect, and this is very real. So as you can see here, from the baby boomer, Generation X, the millennials, and the Generation Z, there's a steep increase in the incidence. And this is despite the fact that in this age group of younger patients, that's becoming a smaller part of the entire population because birth rates are slowing. So this is an important point to understand, the birth cohort effect. And the hypotheses behind this could be linked to diet, sedentary behavior, physical activity, which leads to increased adiposity. Someone having increased adiposity, there's a hormonal interplay which happens. They also have more chances of metabolic dysfunction with insulin resistance. There's more inflammation in the body because of adipose tissue. There's also reduced vitamin D. And we are now investigating also what role the gut microbiome is playing. So all of these factors play into the role of colorectal cancer development and progression. When we look at established colorectal cancer risk factors like increasing age, obesity, alcohol, tobacco, red meat, smoking, diabetes, these are all established in the entire colorectal cancer group. But when we look at early onset, can we hone in on a few smaller number of patterns which we are seeing? Because clearly early life exposure, as you can see on the right side here, childhood exposure, and adulthood medical problems, all of these are playing roles in environmental and epigenetic changes which are happening over time and increasing the rates of colorectal cancer in the young. We also have seen that there are early onset adenomas, which are advanced adenomas. It's important to understand that smokers, higher intake of protein, a higher intake of total fat, red meat, consuming a pro-inflammatory diet, all of these are likely associated with metachronous adenomas. So these are patients who have adenomas when you do a colonoscopy at different time points in their life. So there is a role in your habits and your food intake, which can actually play a role in having more adenomas. So risk factors which actually can are related to recurrence and progression to colorectal cancer, polyp size more than 1 centimeter, villus features on histology, three or more polyps on a colonoscopy, and high-grade dysplasia in terms of the grade of dysplasia of the polyp. This is also a very common situation we see, and many of you would have seen. The patient in front of you is a healthy 20, 30, 40-year-old who is vegan, is exercising, and still gets a colorectal cancer. So we do not understand this completely. But there's also one thing which plays a role. All these protein supplements which people are drinking and eating, there's so much of intake of food materials which are perceived to be bodybuilding or healthy, which we don't know what they contain. So I always tell patients, if you don't understand the labels of what it contains, don't eat that. Just eat natural foods which are much more safe for you. How do we identify these high risk young adults? So it's important to understand that first degree relatives of patients who have had colorectal cancer or who have had an advanced adenoma is that adenoma more than 1 centimeter in size, villus in nature, high grade dysplasia. These patients have the same risk of getting cancer as someone who has a first degree relative with a cancer. So we need to focus on our messaging. It's not enough for patients to know that they had a polyp which was removed. We need to tell them, was it an advanced adenoma? Because that has implications for their first degree relatives. And we do not want to miss that chance to screen people who are at higher risk. So when we look at this slide, you can see here that if you have a first degree relative with advanced adenoma, your risk of getting cancer or high grade dysplastic lesions is much more. And these patients need to be screened sooner than the age. So 18% is what we have estimated in our studies, that 18% is patients have history of a first degree relative with advanced adenomas. And can we improve that communication which is happening? Because right now we have 56% of sporadic early onset, 16% is hereditary, which is the FAP and the Lynch. 14% have family history of cancer, but there's also 14% of advanced adenomas. And that is the group where we believe that communication can be improved. And we have this project running in 3 of our hospitals, where if a patient is found to have an advanced adenoma, they get this tear sheet, and we ask them if they would like to share this information with their first degree relatives. It could be a brother, sister, it could be a child. Then those patients should get screened at least 5 or 10 years sooner than the age of 45. We are also collaborating with our women's health service lines, the OBGYN, where, if you remember, I had mentioned that women are more likely to get colorectal cancer under the age of 50. And we are trying to work with these clinics to improve communications amongst women to get screened. Screening uptake in females is low. In the US, this is the data. Females are more likely to adhere to stool-based screening tests. And the reason sometimes why they don't go for colonoscopy is because they have a little bit more fear about the bowel prep. And also, many women prefer a female endoscopist. So we have work to do. We have to convince more women and, of course, males as well to get screened. Some of the reasons why in females it's likely that early onset cancer is rising is because sometimes the anemia women have may be related or linked to heavy menstrual periods, which may really not be the case, and it could be a right-sided colon tumor which is bleeding over a long period of time. And I think this is where we need to also understand that there are differences in the colorectal cancers in women as compared to males. So, for example, in females, right-sided colon cancer is more common as compared to in males, where the left-sided one. Also, there's a higher rate of the sessile serrated lesions, which are these flat lesions which you can see not easy to detect on colonoscopies. So, anemia possibly wrongly linked to higher menstrual blood loss, right-sided colon tumors, which are different in nature and outcome, and the sessile serrated lesions. So these are the differences between the women and men under the age of 50. This is again a real life patient, mom of 35 with stage 4 colon cancer. And her first reaction was, I never thought this could be me. So these are real life things. I'm sure many of you have seen patients like this. We've also done a survey in our waiting rooms in the women's health offices where a lot of women were unaware that the screening age is now 45. Many of them had doctors who had not recommended that they should be screened at 45. Many women felt that they were having average risk of colorectal cancer, but there was a family history of a first degree relative having either a cancer or an advanced adenoma. And also, very commonly, many patients tell you, I have a healthy lifestyle. I'm a vegetarian. I exercise. My body weight is normal. But that does not necessarily put you at low risk. So it's very important for us to focus on all these points. So, what can we do about it? We can really work with our teams across whichever health system or continuum you're working with, identify how we can plan a program to improve communications about screening and detection. Always engage the community and also work with teams which can help improve your messaging. So marketing teams can be of lot of help in this situation. We also don't miss opportunities when patients come in to get screened. Let's talk about breast cancer screening, colorectal cancer screening, and lung health. And all of these are cancers which can be detected early. In case of course, colorectal cancer, you can prevent cancer by detecting adenomas and taking them out. In this month, we run this Glow Blue campaign, which is really, as you can see on the left side, the number one symptom for colorectal cancer is no symptom at all. And that's why screening is important. We also have a health risk assessment online where someone can go onto our websites and figure out what is their risk of developing colorectal cancer. And I think it's important that these campaigns are not only run through the month of March, but also throughout the year because cancer does not stop once March is over. So, with that in mind, we started this early onset cancer program. This was launched in October of 25. It's a navigated multidisciplinary referral state-of-the-art care which we offer. And these are all our collaborative stakeholders. So it's the gastroenterologists, the OBGYN, the CATS Institute for Women's Health. We have our marketing teams help us. So colorectal surgery, the cancer services program, which really makes it possible for patients who are underinsured or uninsured to also get screened. With our Cancer Institute, we have research partners in the Cold Spring Harbor lab and the Feinstein Institute. We also work with our county officials, the health officials, and we work with population health and community outreach. So it's a really, we have a lot of stakeholders in the program, and we have focused on the two most common cancers under the age of 50, which is breast cancer and colorectal cancer. And as you have seen in the previous slide, these are really the two cancers which are creating problems for our public health officials. So the mission of the program was to become the regional and national leader in patients who are under the age of 50 with cancer. And this should be done by developing a team of multidisciplinary care providers, creating an efficient system for referrals and patient follow-up, develop patient care, integration, and service line collaboration. And of course, all of this needs documentation and data collection, because if we want to improve the program, we need that data and metrics. So, along with Dr. Molmenti, I'm a co-director of the program. The other clinical leaders are Dr. Komorowski, Dr. Kellerman, and Dr. Ashikari. We have a great team of operations which support us, and they not only support the program, they also bring in new ideas. But the key person for us is our nurse navigator. So, what the nurse navigator does, she provides personalized guidance, education, and care coordination for patients. She will improve their experience. She'll make sure that patients get expedited access to care, and also serves as a consistent point of contact, because that's important, right from diagnosis to treatment to recovery. That's where we want to partner with our patients. These are the various pillars of patients who are under 50. We want to help them with oncofertility, with sexual health. We want to help them with financial toxicity through our social workers. We also don't want to miss the opportunity of offering genetic testing, because that may be significant to the patient's siblings and children. We want to integrate lifestyle medicine for improved and better healthy living. And we also want to make sure that we enroll them into research trials and biobanking, because these are cancers which need further research. So this is how a patient journeys through the early onset cancer program. Once they are identified, we confirm the diagnosis. We reach out to their either surgeon, oncologist, radiation oncologist on the case. Their appointments are coordinated. We offer them referrals to fertility and sexual health. They're also referred to our social workers and psychologists. They're enrolled into research projects. With the permission of the patient, we also reach out to their siblings and their children for arranging for them to be screened sooner than a normal average risk patient should be. And then they're handed off to our survivorship team as they go through their treatment algorithm. These are the ways we identify patients under 50, patients who are presented at the tumor boards. So if patients have not been presented at tumor boards, their own doctors can refer them to the early onset cancer program. We also have filters in our electronic medical record system, where with the ICD codes, we actually can identify patients with cancer diagnosis, and that age filter is also there. So once we identify patients, the navigator will reach out to them and help them along their journey. And we also have brochures sitting in almost all offices of our system, where there is information about the early onset cancer program. We also have these are on the left side, you can see 45 take action. That's like a pin which a lot of our staff wear on their white coats or on their shirts. It's a talking point. A lot of patients ask, what is that? And we always answer, 45 is the age to get screened. Have you had your colonoscopy? So that's something which always you want to use, a talking point, make sure that awareness is getting spread as much as possible. We also run symposia. This is our symposia next week. This is the third annual Early Onset Cancer Symposium, which I direct. We have some compelling speakers. A lot of recent research will be presented at the symposium. And, if you are able to attend it, I'm happy to share details with you. So in summary, rising incidence in younger populations of colorectal cancer is a significant health burden globally. And I think this is something which all of us have to take very serious. The importance of early screening at high-risk individuals is important. We need to increase awareness and access to some form of screening. Remember, not all geographies can be offered colonoscopies, but any form of screening test is better than no screening at all. Also, we need to address this unique challenge and disparities in the women's group, where colorectal cancer seems to be more common. Also, I have not touched upon chemo prevention, but beyond screening, we are now working on projects for chemo prevention with aspirin and potential foodstuffs. but that's a topic for another talk, hopefully in the future. And also, when you see these patients with young cancers, you always want to try and enroll them in research studies so that we can understand these better and make an impact in prevention. So with that, I think I'm at the end of my talk. I'll be happy to take questions. Thank you for attending. So I'm going to look at some of the questions. Let's see. If you have anything, if you want to speak, please, let me know, and we'll make sure that you can also come and make your comments. Let me see. Let me invite a few of you. So Professor Kavach is going to join us. He's a professor of surgery from University of West Indies. If you are online, Shamir, please go ahead.
Thank you, Parul. A very interesting talk.
Thank
I note with interest the fact that there's such a steep rise in the younger generations, the millennials versus premillennials. And I can't help but wonder what theories exist to account for that sharp rise in colorectal cancer incidence in the young. Is there any prevailing theory that may explain it?
So I think a lot of theories are basically blaming a lifestyle. That's one aspect, and lifestyle is also being linked to these aspects of the advanced adenomas. So it's actually multifactorial, but there's a lot of it in terms of is it paralleling the rise in obesity, uh, tracking that along with the incidence of certain cancers in the young. Also sedentary lifestyle, the ubiquitous use of the mobile phone has unfortunately played into so much of a sedentary lifestyle, which has happened. So we can't really pinpoint to exactly one or two causes, but there are multifactorial reasons for it. And I'm sure in your practice, you're also seeing these young patients.
Indeed, we are. Thank you.
Thank you so much, Professor Kavach. Dr. Ali, please tell us where you're coming from and your question.
Oh, hi there. Hi, I'm a colorectal surgeon in UK. Thank you very much for your talk. It was very insightful and quite powerful to see the trends and a bit scary really to see what's going to happen in the future. I suppose I think you kind of answered it in the previous question, but what would be your advice to this generation who can sort of see this problem coming their way? And I think you've kind of highlighted on the risk factors, but what would be your sort of top couple of advices or changes that they could make to try and reduce the risk, particularly in the female population? Thank you.
Thank you, Dr. Ali. So, in the last 3 years since I've been focusing very strongly on this topic along with our team, what we have actually seen, and there's a lot of media interest also in this topic because recently you would have read about some couple of very young celebrities who unfortunately succumbed to colorectal cancer. So there seems to be an increased awareness, and I'm encouraged by that. I have young patients who walk into my office who have been able to uh, that media interest has encouraged them to come forward to get screened. Sometimes, because in the US it's linked to insurance, sometimes insurance companies may not cover someone who's below the age of screening. But as long as you can justify it, if there's a family history, if there is any symptoms which are persistent, you can push back on insurance and get those colonoscopies done. But I'm encouraged by the interest young people are now taking, especially because thanks to media interest as well. This is changing, but we are not doing enough. Uh, I don't think I showed you that slide, but 80% is the aim of screening 80% of the population. At best, in the US, we are at around 67%. So there is a gap even in that group where we have to go to. And really, the challenge in all health systems is whatever the health systems can afford, whichever screening tool they have, can you reach that 80% mark? And how do you get there? So, I'll be interested to hear your thoughts as well. But thank you so much for your question.
Thank you very much. I don't know if you could that would explain perhaps why when we do see the cancers in the young population, they are quite advanced. They're past the point of cure. They may have already metastasized. So it's a much more harder situation to deal with.
For sure. And there is good data to suggest that by the time a patient gets diagnosed with a colorectal cancer who's under the age of 50, they have seen possibly three providers before their diagnosis has happened. So that is a published statistic. So it just goes to show that as medical professionals, we need to be more suspicious that someone in your office is not just having hemorrhoids and it could be something more than that. Having said that, of course, you can't screen everyone who walks into your office with bleeding. But I think someone who has persistent symptoms, someone who has family history, someone who's extremely concerned, I don't think they should be denied that screening opportunity. Thank you. We have Mr. Kulkarni Dhananjay. He's a co-founder of SFS. Go ahead. He's joining us from Edinburgh. Welcome, Dhananjay. Can you hear me? So he asked a question, what is the future of screening? Any new methods like ctDNA? So right now, it's either stool-based tests or a colonoscopy in some form. A CT colonography, uh, flexible sigmoidoscopy, etc., really are not screening tools which we are using. So when we use a stool-based test here in the US, we are using Cologuard, which is the fit DNA testing, and it is sensitive, it is specific. If it is positive, unfortunately, you will need a colonoscopy for diagnosis. But Cologuard is a very good test if you're doing, for example, someone who's on anticoagulation has had previous colonoscopies which were not showing adenomas. I think it's a very safe test to do, a stool-based test. In someone who's had consistent adenomas on previous colonoscopies, colonoscopy unfortunately has to be the right test for them to do. There are going to be some blood-based screening tests which are going to come. I am aware of certain tests which are being trialed, but because they are not ready for real-time, prime time, I don't want to suggest that that's something which is already available. ctDNA is mainly used for patients who have established cancer and is being used as uh, follow-up or surveillance. It is also being used to determine whether patients should be offered adjuvant treatment or no. So thank you for that question. We have Dr. Binyam. Can you please tell us where you're coming from and what's your question? If you can please unmute yourself, Dr. Binyam.
So good afternoon, everyone. I'm Dr. Bini. I'm from Ethiopia.
Hello. Go ahead, sir. What is your question, please?
Can you hear me?
Yeah,
So I
I can hear
recently
you.
see a patient, 34 years old female.
Yes.
So she's also in her first trimester of pregnancy.
Very difficult question. So you have a 34-year-old lady, first trimester of pregnancy, and has an upper rectal cancer. That's the scenario, right?
Yes, the colonoscopy showed it's 12 centimeters from the anal bridge.
Is this her? Has she had children before?
Yeah, she's para 3.
So she's had two children before. This is her third,
3 children.
likely. Three children already. Okay.
Yes.
I think it's a very difficult because you'll have to, the discussion has to be also on the continuation of her pregnancy because upper rectal cancer, you might be able to avoid radiation, but based on the clinical stage, the patient may require neoadjuvant chemotherapy and then may need surgical intervention. So it's going to be Obviously, you might have to use MRIs for staging instead of CT scans. I don't know if those are available where you practice, but that would be also. So the way I would approach it is approaching the pregnancy along with their OB doctors, patients' wishes, how they want to proceed with the pregnancy, clinically staging this cancer, and if that stage requires neoadjuvant treatment, then it complicates the issue of the pregnancy as well. So I don't know if that helps you what I'm saying, but that's how it should be.
So thank you so much.
You're welcome. I'm not sure I gave you too much of advice there, but you're welcome. Can we add, there's somebody coming in with rectal cancer tumor board. Can we add that person onto the chat, on the talking, allow them to talk? Yes, I found you. Okay. Go ahead. Please identify who you are and where you're joining us from. Please unmute yourself. I don't know your name, so I'm calling you Rectal Cancer Tumor Board. Please tell us who you are.
Hi, sir. I'm Dr. Taha from
Hi,
Delhi.
hi. How are you? Welcome.
I'm good, sir. Thank you. So actually, it's registered in that name. That's why my name is not coming. The Zoom account, my Zoom account.
Sure.
Okay, sir. It was a very nice and enlightening talk. So I just wanted to ask, from the Indian perspective, since you have worked here as well. So what can we do in India to help our population so that we can detect these cancers early? Because in West it's very organized and you can have screening programs. What can we do at a local level, at our level, to help people?
So, from what I understand, is the obviously, if you have a national screening program, it needs to be justified with the incidence of the cancer within that population. And if that data is not suggesting that there should be national support, meaning public support, public health support to get screened, then the onus really comes on to the private sector and patients. And in that situation, I would rely on patient information and education. And because you are an expert in colorectal cancer, and I'm sure you are seeing hundreds and thousands of patients with these cancers, already you have their first degree relatives as your potential audience to actually get the messaging that they need to be screened. So I would never miss that opportunity, that someone who's in your office with three or four of their relatives, making sure that they understand the significance of the diagnosis of their relative, and that spreads the word. But to justify a public health program, it clearly would depend on the incidence in that population. So that I don't have the knowledge to make that comment in the Indian scenario. But what is your thought? What are you doing?
What I am doing is exactly what you said. I just give a small anecdote. I operated a patient who was 48-year-old with the right colon cancer, and I told him that whosoever is in your family, please get a colonoscopy done. Just 2 months later, his brother started developing anemia, fatigue, and he told the doctor that please go to get a colonoscopy done on me because one doctor has told me to do it, and he also had right colon cancer. He was 45-year-old. I operated both brothers. So what I am doing at individual level is removing adenomas whenever a patient comes to me for say fistula, fissure, hemorrhoid, or any other benign condition. I have removed at least a dozen adenomas in these patients who came for absolutely for not at all for colonoscopy. They came for benign conditions. So at individual level, I am doing these things to help people where cancers can be prevented.
That's terrific. I
Yes.
think obviously all our efforts are adding up, each one of us trying to do this. It's so important. But thank you. And, we should collaborate, really. I have reached
Yes,
out
sir.
to you privately as well.
Yes, sir. I'm looking forward to that.
Yes, no, thank you. I'd like to welcome Dr. Kanere. Dr. Harsh Kanere joins us from Adelaide. He's also a co-founder of SFS. He's an upper GI surgeon, chief of unit in the Royal Adelaide Hospital. Go ahead, Harsh, please. So nice to see you.
Hi, thanks, Parul. Can you hear me? If it's
Yes, thank you so
Yeah,
much.
look, I did put a question up on the chat, and I don't know whether you've seen it, but uh, this is a very interesting topic and a very concerning one as far as I'm concerned, because uh, we are seeing a lot of cancers
Hello.
in
Yes.
younger
Yes.
population, and just in the last year, I've actually operated on about five uh, patients who are in their late 30s, early 40s with gastroesophageal junctional cancers. And this is kind of a difficult scenario where we weren't experiencing these kind of things before. We are now. Is this something that we need to really look into? Not just colorectal. I mean, I think there's a significantly increased incidence of colorectal cancers in younger population. Do we actually need to, um, as a whole medical fraternity, look into things that are actually increasing risks for people developing cancers at a younger age? And what can we actually do about it? Because this is a difficult scenario.
For sure. No, thank you so much. And actually, one of my earlier slides, I had shown that it's the GI cancers which are across the board actually increasing. So the colorectal cancer, of course, because I'm a colorectal surgeon, that's where I focused on, and it's the largest number. But you're right, stomach cancers, pancreatic cancers, all of these are growing, and we are really we're not so sure as to what is driving it. We have hypotheses which are being studied and we're focusing on. But again, in these young patients, trying to figure out what level of suspicion should trigger investigations, how can health systems afford it? Because obviously we can't afford to screen so many young, healthy people. But where is the opportunity we have to figure this out? And I think one opportunity is also to learn from our Japanese colleagues, where they did do this extensive screening. But of course, it was justified by the high incidence of stomach cancers in Japan. So I agree with whatever you said completely. Thank you. We have Dr. Totte joining us. He's joining us from, I guess, Belgium. Dr. Totte, so nice to see you. Please go ahead if you can unmute yourself and speak. Can you hear me, Dr. Totte? So he put in his question that in Belgium, every inhabitant gets a stool sample by surface mail. And if they are positive, they are then invited for a colonoscopy. And they have a national database. Is that possible for the US? I'm sure it's possible, but I don't know whether there's a political and economic will to do it, because it clearly requires lots of resources. And in the US, a lot of healthcare is linked to insurance. So, but it's a wonderful way. I think Europe is doing it, and Belgium in particular. So I would love to have a system or situation where that could be done across the population in the age group which was supposed to get screened. So thank you for that question. Dr. Poddar, please go ahead if you can unmute yourself.
Yes, Parul, good evening from India. I
Good
wanted,
evening.
can you hear me?
Yes, yes, clearly.
I wanted to ask you few things. Question of screening comes later on. First, in a country, you know about India more than me. First, in a country where we practice people having a a constipation, some anemia, and in spite of repeated, they will shop doctor from here to there, and then they will go for a colonoscopy, which is very sad. I'm not saying all of them who are having anemia and constipation are having cancer, but a good number or a moderate number of them will be having some colonic malignancy. I don't know how to take care of this. The second question is don't you think rectal cancer is more among younger people than colon?
You're right. Thank you for your question. I think, yes, there is good data about the rectal cancer part. And in one of my slides, that was the increase in colon cancer was around 90% in 20 years, and it was around 124% for rectal cancer. So clearly there is, and it's more for rectal cancer. Uh, there is a famous surgeon from Cleveland Clinic, Professor James Church, who really was the custodian and the starter of their hereditary registry. And Dr. Church, in one of his communications with me, did suggest that he has certain hypotheses for the increased rectal cancer incidence in younger people. And he was linking that to their bowel habits of younger patients, where there could be someone or a delay in actually going to defecate. And can that retention of stool over a long period of time be one of the hypotheses? It's one of his thoughts. I was intrigued by that thought. I'm sure that he has shared it widely. I don't know how we can study it, but certainly there are different hypotheses which people do share as to why rectal cancer may be more than colon cancer. I think your first part of your question is really patient awareness. If patients are going to meet multiple providers, not going to sort of heed the recommendation of a oncologist like yourself, then I think they are playing with danger. And unfortunately, the cancers will be diagnosed much later.
And I
So
am
thank you.
talking about patients, those who are in a middle class economic society, not about the lower middle class or lower class. But it's very difficult to convince them. I know a couple of my friends into the morning walk when they will tell me there is an anemia, and if you advise them to do a colonoscopy, of course this is on a walk, so it's very difficult for them to convince. They will keep asking, and they will do a colonoscopy when things have really gone worse. You feel really sorry about these healthy, so-called healthy people.
For sure. And I think sometimes when patients come into your clinic and they have been persistently seeing doctors with symptoms, and the doctors have not really triggered the appropriate investigation, that also is very worrying when I see that. And that's why also communicating and educating our primary care physicians and internists is also important, because as experts in treating cancer, we are receiving patients who have already been diagnosed. And I
Yeah.
think it's the wider group of physicians which need that education. And I think all of us have this role to play. As surgeons who treat cancer, we want to prevent cancer. It's not that I don't like operating, but I think sometimes when you operate on these advanced cancers on young people, it's really a disaster for the
Yeah.
entire family.
The other thing I
Thank you.
wanted to ask you again, the continuation of the previous question, that do you think you can do some study, or one of your maybe, I don't work in Tata Hospital, but you have got your good friends working in Tata Hospital Bombay, and you can coax them to do a study? Is chronic constipation, or is one of the reason for cancer, colon or rectum, which
I
has
think it's a
been.
good questionnaire to serve, to just have bowel habits. There are scores which we can study, when patients fill out questionnaires. I'm sure we'll talk to Dr. Ashwin D'Souza. Yeah, it's a good question. I'll when I meet him, I will bring this up. Thank you.
Thank you very
Um,
much.
thank you. We have Dr. Ajay Punpale. Go ahead, please. Ajay, welcome. Thanks for joining.
Yeah, sir, good evening. Nice lecture. I know the question I have asked is like, is there any role for community screening? And if yes, how is it possible to do it in any way? Though I know that it's a really challenging situation to do a community screening, but then what can be done? Because even like I'm practicing in Latur, Maharashtra, and for last 20 years, Even I have seen a trend that young rectal cancers are increasing. And most often, when we see these young patients, they are really advanced or metastatic by the time they reach.
I think it's a great question. I think great opportunity for, and I'm sure you're doing this, because I know that you also may be having your own, cancer setup. So
Yeah.
anyone who walks into your setup actually is the visual bombardment of information about prevention and screening, I think is the opportunity you want to use. So that would be really my approach. And I always in our waiting room in our offices, we have so much information about the screening, about the incidents, about the lifestyle, and a lot of patients always pick up those brochures, and we always encourage that. And I think that's possibly one of the opportunities we have is a point of contact with the patient. And because
Mhm.
patients come with their relatives or friends, I think we have a second point of contact there. So that would be my approach. I
Approach.
don't know if
Yeah.
that's helpful.
Yeah, so I think more than screening, I think probably the best approach is try and increase awareness by
Yes.
whatever means. Because like most often we face head neck cancers more often than rectal cancers. But as you just do only colorectal cancer here at Latur, we end up doing almost all the cancers we need to treat here. There are no specialized only colorectal surgeons or only head neck surgeons. So I think, as you said correctly, when I see a head neck patient also, so I have that opportunity to at least kind of sensitize his relatives, and
Yes.
yeah, that's
And
how.
many times, we have patients who like, oh, I don't want to get a colonoscopy because I have to take a prep, I have to take a day off, I'll need somebody to drive me home. And actually, a patient of mine on a public forum said something which really stuck in my mind. And he said, and he's now an ER resident. He got diagnosed with rectal cancer before he went into medical school, so young. So he told that person, he said, you can't imagine how much problem you get when you actually get the cancer. It's nothing compared to having a colonoscopy. So screening is so easy. And when you compare cancer treatment of surgery, radiation, chemotherapy, there is actually no comparison. And I think
Comparison.
that's where we need to tell our the population that maybe one day you may be inconvenienced to do screening, but treatment of cancer will take you a year.
Definitely, definitely, definitely,
Thank you
sir.
so much.
Yeah, thank
Thank
you,
you.
sir.
We have Dr. Uzma. Please speak. Where are you from?
Yeah, I am from Pakistan. Actually, whatever my experience about the 8 years working in the oncology department, surgical, I have seen many young patients in the 20 years, 15 years, teenagers, and they present with the metastatic disease. You said that the 45, most of them have a regional disease, but I have an experience of the youngest patients with the metastatic disease. So, do you think there's any molecular biology that is changing with the generations, and or this is another kind of the disease or pathology we are seeing in the new generation?
So this is a great question, and I think a lot of the advanced stages we are seeing is linked to the late diagnosis of these cancers because the patients who are younger and when they are in front of a doctor, the doctors are not suspecting cancer. Now, whether the biology is worse, that's a different question. Now, that requires some more testing in terms of molecular research, etc. But clearly, one of the common reasons why patients with younger patients with cancer have advanced disease is because they are diagnosed late. That's the real reason. Great. Thank you for your question. We have Dr. Abu. Can you please tell us where you're from and if you unmute yourself and ask your question? Hopefully, that'll be the last question. We are going to be on the hour after that. Dr. Abu, please. Okay, let me read his question. He writes, which lifestyle factors strongly contribute to early onset cases? I think it's smoking, red meat, sedentary lifestyle. So those are really amongst the most common reasons. So thank you all. It was a very nice session. We'll be back with the next webinar. I think it's going to be a very interesting one. You'll hear from the SFS teams about the subject matter and the speakers. So wherever you are, have a great weekend and thank you for joining. Bye.